Mittal sir, please start.
Sure.
No.
This is a 21-year-old male patient with MRD 272036 diagnosed with pilonidal sinus. He came with the complaints of pain in the nasal cleft region since 1 month with opening, has a past history of Crigler-Najjar disease. On examination, there was an opening in nasal cleft. On investigation, CT sinogram suggestive of pilonidal sinus tract extending from the gluteal region at S3, S4 level with a blind end in the rectococcygeal region. No evidence of communication with sacrum and coccyx.
Hello.
Yes, we can hear you, Kushal.
Okay, you can hear me, right? Can you hear me in the hall?
Yeah, we can hear you. Can
Okay.
you show the external view of the patient?
Okay, the patient is in prone position. The buttocks are strapped. You can see the strappings, and no pillow is required underneath.
Okay.
This is what we call as he's had an abscess and it's drained. We should not impart or go in for major flap surgeries in a minimally infected pilonidal sinus region. Now, when I first saw this patient, everyone suggested the opening was here, right? Though this is not the opening, it's here. This is the opening. How do we know? We took a photograph with a mobile and enlarged it. Then we see the openings are here. There are two small openings, and this area seems to go down. I think they did an MRI. It's saying that the tract is going backwards. So what I'm going to do, people are going to ask me later on, can you do this under local? Yes, you can do this case under local anesthesia. And what you do, I'm going to show you the staining and how local is to be given in case of minimally invasive surgery, even laser in pilonidal sinus. So the area I'm going to give local to is like this, like a box. You can see that. And the area other I will give is around this place, going deep. Ideally, if the patient is the undershot GA, I would give Xalocaine, adrenaline, that's all. I don't need to add bupivacaine. But if the patient is under spinal, then instead of lidocaine with adrenaline, I use saline adrenaline. How do we prepare this saline? 100 ml of saline bottle, add 1 ampule of adrenaline, that's your solution. And that's what you can inject so that there is no bleeding or less bleeding. Now I'm going to take this all away. What I'm going to give is modified saline adrenaline. That means I'm going to inject it here because once we cut, it's going to bleed. This area is vascular in the sense it bleeds a lot.
Sanjay, I think let this MIPH he's waiting.
Yes, Nitish, what are you doing? Can you come up?
So 1 second, you're not audible.
You
Please,
can take the
we
mic
get
to Nitish.
Can we get the audio to Dr. Nitish, please?
You can't do it. Yeah,
Yeah, please do it. Mittal sir said yes, please.
Yes, you can shift the
No
audio.
problem. Let her. Yeah, am I audible now? Yes.
Yeah.
So now what? In the meantime, when I had time, I have just packed it so that there is no edema in that or congestion in the hemorrhoidal tissue there. What the next step is to fire the stapler. Now, before we do that, we have made sure that the bursting is complete. We have taken the belt loop at around 3 o'clock. 9 o'clock we started. We, overrun the entry point. So I have just passed the entry point by taking a bursting suture little beyond that. Now, next step is to make sure which stapler you are using. One, usually we use a 34-1. I these days prefer using a 3-row, which gives you a better hemostasis, but 2-row is equally good. These are the marks which gives you the distance from the anal verge. When you close the stapler, you should either just see a part of this 4 mark, or you should not see this at all. It should go inside. That is one. You open the stapler fully so that you are able to go beyond the bursting suture. Then this window will tell us where we are going to fire. Once it comes in the green zone, then the stapler closing comes to the ideal form of B, which these staples form. This is the lock which should go off only once. because you are supposed to fire only once. If you fire twice, you will staple once, but you will cut twice, and then there will be torrential bleeding. So you open this once, fire, and close this. That's all. This is the knob which helps you closing and opening the stapler. We'll talk about this when I actually do it here. So now what I have to do is I need to remove posturing endoscope, direct it towards the sacral hollow and nose of the patient so that I remain in the midline and little bit down. I'll get a feel of give when I go inside, and that is where I know that I have gone beyond the posturing. And when we were
Nitish, tell the audience if it's a female patient, what extra step you will take.
Yes, so we need to be careful that we should not take the posterior wall of the vagina. So when I close the stapler, I'll try to lift the posterior vaginal wall by using a tooth forceps, one. And secondly, while taking the suture, I will be extra cautious, not going too deep here. In the meantime, when we were not, when I was not talking to you, Ritu, you need to support this. Let's leave rest of things now. Support with proper this thing. Fine. So now I have gone beyond this point. And what I need to do is, belt tube is already fixed in its position. And now I am taking control of both the ends of the posturing suture. So what we need to do is avoid, just 1 minute, ma'am. Can you just hold this? So this is the posturing and this is the counter stitch there. So what I need to do now is to try and tighten the posturing. Now it is a monofilament suture which we have used. If you do a motion like this, the movement like this, that you're pulling one end, the other end should go in freely. So you make sure that you have not locked the suture in between. When you do this, there is no undue pressure on you to tighten the knot in such a way that there should not be a loose donut. So I keep it almost of equal length on both the sides. Once I have done this pulling and pushing movement, as you saw me doing this, afterwards I take a single knot. Now when I take this knot, make sure you guide it with your finger, and there should be enough space for you to go inside. If you find that the space is too less, that means there is something wrong. Either you have not gone at the correct distance from the dentate line, or there is some other issue. So single knots, you keep on pushing. You can take 2, 3, whatever suits you. Give me a suture threader. Now there are 2 windows which are, or rather 4 windows which are provided on this side. You need to railroad this thing through this. A good practice is to go across, cross this and pull it out. The moment you come out, just a mosquito please. You need to fix it with a mosquito. That makes your job a little easier. There is no chance of losing it in the bargain. Now little careful on the belt loop side, because we have not tied the knot here. So accidentally, if you pull only one end of this belt loop, the whole thing will come out, and that will beat the purpose. And at this point, you won't be able to go in and take a belt loop again. Now there may be a logical question: what if it comes out accidentally? Answer is, don't do anything. Go ahead and do the procedure as you like. The second thing is to hold the stapler in this particular manner. My middle finger is in the loop which I have created by holding the sutures like this.
Hold.
If I want, I can go little closer, because as I close, this may come little close to my thumb.
Hold.
The thumb is at the locking position or the lock. I am directing it towards the sacral hollow, and then I start closing the stapler.
Let him
Auditorium.
fire the staple, then we'll shift to the other side.
Hello.
Hello?
Sir, Mittal sir is ready for surgery. If,
Just one
Yes,
minute,
just
1 minute.
Dr. Mittal, hold for a minute.
okay.
Let him fire the stapler, then we'll go to you.
Sister, give me a gauze like this with jelly. So now you can see I have closed the stapler, and you can see the number 4 disappearing in that circular renal dilator. Is it visible to you there? And this has come in the firing zone. This particular orangish mark is in the firing zone. We are at the perfect B. It is at the 4 point. I'm still maintaining the traction. I'm waiting for the fluid to move out of the donut, which I have already taken in my stapling device. Wait for 30 to 60 seconds here. 30 seconds is recommended in all types of staplers. So whether you're doing here or in GI tract, this is the principle which we follow. Now I'll try and tighten it a little more. Now, once we have waited and done this procedure, I really can't tighten it more than that. Even if you are very strong, you're a regular gym goer, please don't try to overdo this. You may break the knob. Once it is in the firing zone,
Nitish,
you
could
have
you
no
be a bit,
business closing
hello,
it even more.
Nitish?
Yes, ma'am.
Could you be a bit fast because Kushal
Yes,
is
yes.
meeting?
Yeah, no problem. I'm just firing. Just take these instruments, otherwise I'll miss my chance. Okay, so now this thing, while firing the stapler, it is a good practice that you do it in a stand. Sister, give me a mosquito, please. You do it in a standing position, because if you want to do it in a sitting one, you may not be able to generate so much pressure to close this. Most of these staplers, they have a feedback. You will hear a click when I fire this, and this is how it fires. Afterwards, just let go, lock it in one attempt only, no further firing. So once you lock it, even accidentally, you won't be able to do it. Now, the second thing
Kindly
is to open
audio
the...
of Dr. Kushal Mittal, sir.
Okay, so I'm not audible anymore, right? Yeah, I'm still audible. So I'm opening it by 270 degrees. Then you rotate the stapler on both the sides. Dr. Nupur and Ritu, they are
We
holding the
go to
CAD.
Dr.
And I
Kushal.
just come out with a fishing movement and then immediately pack the
Audio to Dr.
cavity.
Kushal Mittal Theatre.
Fine. So we just have to show them the donut, and that's it.
Kindly shift the audio to Dr. Mittal OT.
Yes. So this is the donut. Once we show this, I think this completes the procedure. And this is a complete donut. You can see the distance. We have measured it, and there is no perirectal fat in this. This is a reasonably long one, so that it shows that the prolapse was little more at the 11 o'clock, so that we have taken care of this, and the donut is complete on all sides. So this pretty much finishes the procedure. What remains now is to take
Shift
the
the audio to Dr. Mittal's
Sir,
OT,
doctor,
please.
sir, we want to show we are the, shifting audio to
first thing
OT2,
anoscope.
Dr.
First thing anoscope.
Dr. Kushal
Yes,
Mittal,
Dr.
sir.
Kushal, we are
Yes,
ready.
Dr. Kushal, we are with you now.
Okay. Sanjay, you're there. So any questions regarding the instruments, you can tell them. This is the Store's waft scope. It's 3.3 millimeters at the tip. It's 3.3 millimeters
yes.
at the tip. It's got a working channel of 2 millimeters through which your forceps and your
in BPH
for
there is a
cautery
bleeding.
and
Let us see
for
how
brushing
the
can be
bleeding
put
is
in.
being handled.
You can see that.
And
You can see
the
screen is open.
instrument is for pilonidal sinus. You may have to take out the handle, because if it goes too low, then you have to take it out. Otherwise, you use it. Irrigation, since I'm not going to do cautery in it, I'm going to do laser in it. I'm going to be using saline, and it's best if you use a TUR set, because IV sets are very slow irrigating. And that's how the कहाँ से बंद किया? That's the flow. Now here posteriorly वो दूसरा चाहिए, metal. Stores वाले नहीं आए. इसके पीछे वो three-way metal नहीं है उसके पास. Okay, now I'm going to show you the wound. Okay, gauge.
Yes. You can see a small bleeding on the MIPH case, and he is taking the figure of 8 suture.
Okay.
You can observe on the screen on your left.
Now, methylene blue, sister is going to give me. So how do you mark out? These are punches available on Amazon, and they cost, a set of 5 punches will cost you 300 to 350 rupees. They are single use. What you do is you take methylene blue in a bowl, you dip it, jerk it, and here, pakdo. And I'm going to mark the opening. Okay, and then clean it. I have to see, does it cover? So I am going to make a punch here. The punch is complete. I take it out and lift it, clean it. You take this disc out from the base. Okay, now that's what comes out because I punched it. Now with a mosquito, I'm going to go in and see what's inside. Unhealthy tissue, hairs I have not got yet.
So you can observe Dr. Mittal is now removing the epithelialized part of the tract, the so-called pit, which is communicating with the underlying sinus cavity.
You
The
have
skin
to
is
do this.
communicating through
Give
these
me a
tracts.
watch, please. Okay, then I put in a curate. I'm doing this step first to show that people who are doing just lasers, what if you miss something? I don't think you will miss anything, but still, now this is a hair. पकड़ो. So I'm taking, दिखाओ ना इसको, strangulate मत करो. So I'm going to first make sure there are no hairs. Then I'm going to put the scope inside.
Dr. Mittal is doing this step to tell you that what is the advantage of doing the scopy. That is the under vision guarantee
Okay.
of removal of hair.
Now
It is
we
first
are going
removing the hair.
to start the irrigation and put the scope inside.
Yes.
Suction. So can you see the scope view?
Yes.
Sanjay, can you see the scope?
Yes, yes, we can see the scope
Okay,
view.
so what I'm
Now
looking
it
for
the
is
outside. Yes, now it is the inside view we can see. And we have a picture in picture. No problem.
you have to do here, lowest part. So basically what I'm looking for is even a single strand of hair, and on which wall is the unhealthy tissue. Okay, so we didn't get anything, but last week we did a case in which the sinus looked, there's nothing there, we curated, took everything out. The moment we put a scope in, there was a balled out, on the left margin there was a balled out bunch of hairs. So if those hairs don't come out, then it's going to be a problem. Now I'm curated once again, chashma deo, laser ka.
Kushal?
And you don't have a WAF set, it's okay, use any set which is 3 to 5 millimeters in size but has a working channel for irrigation and putting instruments. Now how do we put an instrument through this? Wo deo, grasper. If it's small, hold here and hold here, close.
Dr.
Now
Kushal?
see how the sister's introducing it. Okay, that's the grasper, it comes out. The grasper, if I have anything inside, I'm just showing it for demonstration. ये saline bottle पे pressure देना. Okay, you need more pressure because with the grasper the working channel becomes smaller and the irrigation becomes less. So if there's nothing there, don't do it unnecessarily. I'm just digging in to see if there's any hair anywhere. No. Unnecessarily do not keep exploring. Okay. Now we are going to take the laser fiber. देखो radial fiber किधर है?
If it is a long cavity, it is advisable to do the scopy from both the sides. Dr. Mittal, tell them the importance of that.
Okay, something beautiful about this radial fiber. Can you see? This is a infinite fiber. Huh? Infinite ring fiber. So it's got 4 rings. Instead of 1 ring, it's got 4 rings. So that means uniformly is going to do it. Now we're going to introduce this. My foot switch, I had kept it locked like this. Open it. चश्मा सिस्टर को नहीं बनाया. एनेस्थेटिस्ट कौन है? इनको बनाओ. So this step is important. Please get everybody in the OT to wear it, including the anesthetist, because if my fiber comes out and you're standing there, it's going to hit you. Not this one. This is go rubber pen lo. Okay. Who is with the camera? Chandrakant. Chandresh. Yes. Chalo. The fiber. Inserting the fiber inside. Cleaning it. Next suction. दूर करो. Okay. Ready? Gauge piece. हाँ on करो. Sister gauge. Sister gauge. So what I advise is, in order the tract touch everything, ये हटाओ wound उसमें आ रहा है. Press on the gauge. 10 to 12 watts. Yes. Patient को shivering है. Okay. 10 to 12 watts millimeter per second withdrawal. So I'm just waiting. Patient is having a little shivering. So don't be in a hurry to take it out. It's 1 millimeter per second. This tract is, I think, about 2 centimeters, 1.5, 2 centimeters. That's 15 to 20 seconds. Machine ka view aa raha hai. Okay. So I'm out. I take my irrigation cannula. I mean, routinely, if you don't have this instrument, now I'm irrigating it. See inside how nicely it's burnt. Now sometimes once you burn it,
We are not getting the inside view.
inside view please. Can you see? ये बाल लग रहा है क्या? नहीं.
Yes, now we can see the inside view.
ये hairs ये exit पे ही है. नहीं अंदर है.
Sir, one question.
ये देखो hairs दिख रहे हैं?
Hello, sir.
Yes.
Okay.
Please ask, can we insert this laser fiber through the scope?
Yes.
Is
We
the
can.
diameter of scope?
We
Yes,
can.
yes, you can.
देखो Naresh, the reason I didn't show that is I wanted to show people with laser how they do it. More people have laser than waft. Yes, I do that. How do I do that later? First I do this, and whatever here skip areas are left, I do it. Now, for
It's a fast.
sister दो हाथ इसको पकड़ो.
Yes, that's the
Sister
problem.
clip लगाओ उसे. Okay, now I think 2 hairs have come after burning. Let's see.
Kushal, can I interrupt you?
Uh,
As per MCI guidelines, I think the moderator will answer your question. So Dr. Sanjay is answering your
Okay,
question.
okay. I'm just saying I've got the scope inside and I'm looking for hairs. I think this is a hair. I'm going to come here and take it out.
Yes, you can use the scope, no problem. As he already told you, he is demonstrating those who don't have the scope. But it's advisable in the modern practice to have the scope so that you can remove every bit of granulation
So I'm
tissue as
taking
well as
out-
the hair under guarantee of the vision. That's the advantage of the scope.
That's small hairs which came out after I had.
Dr. Singla,
Yes.
can we use
So-
a cystoscope or hysteroscope just to look at the cavity?
Earlier people used hysteroscope, but this scope is very sturdy. It doesn't bend, it doesn't break that way. But the other scopes are fragile in that regard. Number two, the hysteroscope, that cystoscope is a rod and lens system. The chances of damage are more. These are actually, they are rigid, but they are fiber optic scopes. That's why you can see small impression like a thumb impression.
You
You can
see
see over
how
the
to
screen.
take it
I'm
out like
talking
that.
about those who don't have a fistuloscope.
They should purchase.
Okay.
No. Accurate.
As you saw, Dr. Nitesh Jhamar being operating the case
Accurate
of
और दियो इससे बड़ा.
we all have seen a small complication like bleeding. So MIPHs can also have
इस पर
some bleeding
size
sometimes,
millimeter
which is been
length
tackled
के
at
ऊपर है.
pressure and
Okay.
stitches.
So 12 watts per millimeter.
Dr. Singla,
नहीं नहीं
Yes.
basically, I
even
know
for
you
fistula
is
it is not
doing the
limited.
WAF,
Limit is
but the
in
main
fissure
pathogenesis
and
of
hemorrhoids.
cleft,
Can we
the pilonidal.
can we have audio in OT1? Dr.
Nahi.
Nitish is injecting
Irrigation.
methylene blue, and you'd just like to.
ये
Any questions for Dr. Nitish Jhamar from the audience? For MIPH?
So just for the sake of audience,
So-
just want to know how he managed to tackle the bleeding.
Okay, I'll just pass that on to Dr.
So he
Nitish.
managed with number one, with resilience and perseverance. He washed every bleeding point, then did a suture with a Vicryl 8 shape suture. He took all the bleeding points over the suture line, and that's how he could control. The message is you control it with sutures. Don't try to apply
Dr.
any
Nitish
sort of
has audio
electrical
now.
energy because there are already clips, metallic clips are there. So don't try to use any electrical energy or any bipolar or something like that. Always apply sutures.
Dr. Nitish sir, audio is already on.
Yes.
He
So
wants
now,
to,
see, you. I think I'm glad that there was bleeding when we did that, and that is why initially I was telling you, if you use a triple row stapler, the chances of bleeding goes down. Now, second thing, which Dr. Shingla sir pointed out very rightly, you need to be very patient. Don't worry. Even if you are operating in a conference, you need to don't try to look good. You have to give enough time to locate the bleeding point. Now, if the bleeding point is from the staple line, you have to take a figure of 8 stitch. Yeah. Yes, control. So, you have to take a figure of 8 stitch covering the staple line. So, take the stitch above and below and close this. If the bleeding is coming from below the staple line, then you just need to pack and wait for some time. Mostly it stops. Now, we use a 2-0 to control the suture line bleeding or a staple line bleeding, but if it is from below, if you use a 3-0, that will be better. Examine it quadrant wise. Don't remove this CAD till you have finished the whole thing. And in MIPH especially, it is important to have an impeccable bleeding control on table, because post-op, if you get this bleeding, this can be torrential. So this is one of the things that you can have an incomplete donut, you can have the bleeding. These are the two common complications. You can tackle both by taking figure of 8 stitches.
Thank you, Nitish.
So,
Thank you.
thank you, Nitish.
Thank you for the good presentation.
That is why he has shown that he has kept the CAD till the end.
Yeah.
Some people remove
Auditorium.
the CAD when they remove the stapler out, but he has kept the CAD till the end, and that is the advantage that you can
Hello.
see the any bleeding and the things.
Auditorium.
We shift to the Dr. Kushal Mittal's OT.
Yeah.
Kindly shift the audio to Dr. Kushal Mittal's OT.
Sir, a question. Where should the methylene blue be injected, in the circumferential pattern where sir told, or at the stapler line? There are two consensus. What is your opinion on that?
There is no need to put the methylene blue at the staple line because that is above the dentate line. He has just put the methylene blue where he has taken the stitches to decrease the pain. That's all.
So only to decrease the pain of this sutures, or
Only sutures.
cat sutures?
Well, some people they use the methylene blue in a block to decrease the pain.
अरे वो कौन बात खत्म नहीं होगा, वो चलता रहेगा.
He gave a put in
Hello.
the block.
Sir, Dr. Mittal wants to point some points.
Yeah. Those who are doing laser, remember,
Parvez wants to
curate. Can you hear me?
He's just saying something.
Yes, Dr. Pravez, we will take your point little after, and Dr. Mittal is going to tell us something about the laser. Yes, continue, Mittal.
Okay, can you hear me?
Yes.
Okay. When you do pilonidal sinus by laser, first curate, then laser, then curate, then laser, then curate. You start with curate, you finish with curate and do laser twice. What I've seen is people do curate, laser, and that's it. And these patients have recurrence. So now second time I'm going in, you see this tract. So koi pressure there. Okay, I've cleaned it out. Now, as Naresh pointed out, can we not put it in? Now this is the new fiber, infinite, which has 4 rings. Chalu hai? Now,
Laser fiber he is using as a little wider
Okay.
window for the laser delivery.
so what you do is, you fix your fiber here, in the end, and don't move it. Take your scope out and don't move it. And stop You see this fiber?
Yes.
See outside? Can you? I'm pinched it. So it's not going to move because I'm going to close the irrigation and you are going to press. Let me see the repositioning.
He has stopped the
Okay.
irrigation little less or a stop because now the track will collapse over the laser fiber. If he keeps the water flow on,
Not now,
then the
ho
track
gaya.
will not collapse over the laser fiber. So somebody asked that whether he can use the laser fiber without the scope or with the scope. That's the advantage of using without the scope, but then you have to refulgurate the areas which are the skip areas.
छोड़ो देखें
Dr. Kushal, will you go down also to do a scopy in the lower part of this thing, or only you'll explore this area?
Dr. Sanjay will answer your question.
Yes.
See,
we
you
should
see,
scope the
you see
we should
this?
scope the track from both the
Sanjay,
sides if possible.
Sanjay,
Yes.
this hair was embedded in the wall. I'll just show you. We just saw hair. कहाँ गया?
These are not hair. They are most
this one.
fiber.
See?
Yes, there is one hair.
Chalo, forceps. So even a single hair will reform the whole thing.
Yes.
इसको पकड़ो.
Sir, can I ask?
यहाँ से.
Sanjay sir?
Yeah.
Yes, yes.
Some people
दो
just
हाथ है ना, इससे पकड़ो, दूसरे
some
suction
people
करो.
laser ablate the track
नहीं, दूसरे
and
suction
they
करो.
don't curate it. They just leave it. They tell that the laser ablated walls are usually sterile. They help in healing. There is one consensus. What is your opinion on that? Should we curate
Pardon,
it?
tell me again.
Some people, what they do is they just laser ablate the walls of the tract and they don't do curettage after that.
They don't curate after that.
They don't curate after that. They tell, firstly, the laser ablation
अभी
is
मालूम
sterile,
पड़ेगा?
so it is not needed to curate it back. And also sometimes they are saying that it will stick up. So what is your opinion
No,
on
no.
that? What is
There is nothing like stick up. It's not the vein. The concept, use of laser in the EVL is different. Concept of using laser in the track is totally different.
Okay.
They are not, here the
Okay.
walls are,
Curate.
we are not trying to glue the walls. We are just ablating the granulation tissue, the pseudoepithelium. We should always curate after that because if there is a lot of dead material lying there, it will go on discharging and the healing will be delayed. You should always curate after using the laser.
Anshul,
In this
Nidha
track.
said that you first laser, then curate, then again laser, then curate. He does it 2 or 3 times.
Yes, Sanjay.
So that answers your question.
The idea is then once you do the laser, then you do the curate and then you watch again. If there is any
Betadine
unfulgurated area,
ointment
you
le lo.
fulgurate that. The second time laser what he is using is that is with the intent to just decrease or to come some contracture or some decrease the diameter of the track. That is the idea. But if you are vigorously doing the laser,
Mosquito.
you should always curate or watch with the scope that if there is any dead material, you should remove it.
Thank you, sir.
नहीं वो फैट नहीं चाहिए.
Sir, good morning. Is there a huge chance, huge difference in the recurrence if we are using only laser and laser with a scope?
Yes. There are 1 or 2 randomized trials also for that.
मंडी ओपनिंग ज़्यादा मजा आता है.
Using lasers only or with the
Okay.
scope.
This
They
is
have not been found
can't
because the
betadine.
study was only 23 cases were done. So they are not able to come out with any specific results. But yes, with the common sense, if
You
we
are going to see
understand
now.
that
Post op, you
we
have to
have
just
seen that
irrigate with saline. That's all.
certain time the hair are embedded in the track. And if you don't have the scope, those hair
हाँ.
will be left inside. So in the modern
क्या
practice,
है?
it is advisable to do the scoping.
देखो ये.
It's always beneficial.
Yes.
But because so many are
अरे
using
expired
laser
तो नहीं है.
files,
Color
but,
देखो ना.
Not with in the scope and laser together in the pilonidal sinus.
अच्छा betadine solution दे दो.
Difference. Then why should
मैं ऐसा
spend?
नहीं लगाऊंगा.
No, there is a difference. Though statistically not yet proven, but there is a difference. We have seen it. But the cases are not done from many centers. That's why we have not come out with good, robust studies for that. But whatever our observation is, there is a difference. At times, you have lot many hair inside still embedded in the track. And if you don't have a scope, you will miss all those hair.
Okay, sir. Thank you.
So I'm just dressing it.
A traditional thing I wanted to ask in here, if you see the main pathogenesis of pilonidal sinus which has come up is because of the cleft which sucks in the air, goes inside, causes a sinus. If you look here, there is a pit lower down,
Yes.
Yeah.
which is going to remain. So how do you say that, what's going to take care of that, and is that not going to be a chance higher of recurrence? Because you have not only tackled one part of the pathogenesis, but the cleft, which is mainly the thing which we used to deal with, and make it more straighter to avoid the cleft, which was the main line of treatment, that is not going to be dealt with at all.
There are three factors for the hair, pits
Chalo,
and the
watch
cleft.
please.
And even after you remove the cleft, there is still a recurrence because there is a formation of new pits also at times. So we are not, yes, with this you are removing two factors, one the pit and what are the already the hair inside. We err on the side of removing more pits. They may not be communicating, but we remove all the
Okay.
pits once we handle it. And later on you have to be observant and you should do the epilation for long.
Sanjay, his question was, there's a pit, there is a hollow
Yes,
there.
yes, yes,
That
we understand.
is the precipitating factor for the pilonidal sinus.
Yes, yes, yes. The reason is
For people who are not doing laser, that is the best option.
yes, yes. There are core factor of recurrence. Number one, late recurrence, and the other factors of like days off the work, because this is a disease of people who are actively engaged either in the full-time studies or in the